What's up, Nurse.org? Good morning. It's Em. It's your favorite oncology nurse, and I'm officially taking over Nurse.org's Instagram. I'm super excited to show you what a day in the life of an oncology nurse looks like, specifically an oncology clinic nurse. I'm just here caffeinating, getting ready to go here, but I'm super excited, as you can probably tell. So definitely hit me up with some questions. But yeah, I'm going to be talking throughout the day, just kind of showing you what I do, introducing you to some people that I work with, I really enjoy working with. And yeah, sharing some tidbits about oncology nursing, stuff that I really like. And yeah, hopefully it'll be a good time. What's up, Nurse.org? So I'm on my way to work, and I figured I would use this time to kind of tell you guys a little bit about what I do. So in my introductory video, I told you guys that I was a combined medical oncology / supportive care nurse. And what that means is I work both supportive care and medical oncology clinics. So I cross-cover clinics. And I knew that when I accepted this job, they told me I would be cross-trained to cover a couple different clinics because we kind of do that, which is cool for me. I really like, the challenge. I really like being kept on my toes. This week, for example, a bunch of my colleagues are on spring break with their kids, so a little bit of a bare bones crew here. I'm cross-covering a bunch of different clinics. Like today I'm covering telephone triage. Yesterday I did GI. Tomorrow I'll do supportive care and genetics, and then Thursday I'll cover another GI clinic. So hey guys, so I keep using the term medical oncology, and I figured that you guys may not know what that term actually means. So I'm going to provide a little bit of explanation here. So in oncology, there are different subspecialties. So medical oncology specifically refers to solid tumors that are being treated through medication. Oral or intravenous antineoplastics. There's also surgical oncology, which obviously that's pretty self-explanatory. Radiation oncology. There is hematology oncology, which covers blood-based cancers, so lymphoma, leukemia, MDS, and multiple myeloma. There is gynecology oncology, which is its own little specialty because it's a combination of kind of med-onc and also surg-onc, as well as BMT, which is again a whole nother beast of its own. BMT is kind of like the ICU of oncology. So I work specifically in medical oncology. That's where all my experience comes from. I actually know very little about hematology oncology, so I have to kind of study up on that before I take my exam. But yeah, hopefully that helps and provides a little bit of clarification on what I mean when I say med-onc. Guys, so I'm on a little bit of a break. So I figured I'd use this time to kind of tell you a little bit about what I do as a medical oncology nurse versus what I do as a supportive care nurse. So as a clinic nurse in a medical oncology clinic, I see patients with my provider. I go and I assess them. We have to do some basic assessments like pain, falls, and then sometimes we have to do a more in-depth assessment pretty much to identify any needs that they may have, case management needs, nutrition, social work, that kind of stuff. And also obviously assess them and see if they're having any side effects from their chemotherapy. That's really important. Then we report back to the doctor, and we do that for every single patient that we see in the clinic. We also do a lot of prior authorizations. We handle phone calls, obviously my chart messages. Anytime you send a message to a provider, it's the nurse in the clinic that's answering them. We interpret lab values. We do all the stuff. So we just talked about what I do as a clinic nurse in a medical oncology clinic. It's very different from what I do as a clinic nurse in a supportive care clinic. So supportive care or palliative care is all about symptom management. So we are very focused on symptoms, obviously. So we have very different assessments. We are very focused on a particular set of symptoms that we have the patients rate prior to meeting us. And what we do is we pretty much deep dive into all of those symptoms. And then, we kind of offer suggestions if we can for all of the symptoms. Like for sleep, we optimize sleep hygiene. For fatigue, we optimize, energy conservation, and then we relay all that information back to the provider, and they will talk to the patient and kind of offer suggestions as well. But it's very different because we focus primarily on symptoms and really nothing else. So that's pretty cool. So we finished up our work day. So this is the 5 week for me, which means I work 5 days a week. This week, and my hours are 8 to 4:30. Sometimes I work 4s, which is 4:10. So my hours are 7 to 5:30. My preferred schedule is the 4:10s because it means I have a day off in the middle of the week. 5:10s kind of sucks because you can't really do you can't really do your doctor's appointments, the stuff that you need to do during the week because obviously you're working. So that kind of sucks, but it's a 5 week because a lot of people are on vacation this week because of spring break. So here I am. But we're about to head home. It takes me about 20 or so minutes to get home, and then we will kind of deep dive a little bit more into some oncology specific things like certifications and whatnot. What's up, guys? So I'm home now. I just ate dinner. I feel good, and I figured this would be a good time for us to discuss a little bit about the different roles that you can work in oncology. So I like to tout oncology all the time because there's so many different subspecialties within oncology. So there's a lot of opportunities for jobs. I have personally worked all 4 of these roles. So I can speak from experience for all of them, and we'll kind of break down all of them, the pros and cons of each. What's up, guys? So this is a really good question. It's one of the questions I get all the time as an oncology nurse, and I have to say that I actually love the oncology patient population. The patients are the reason why I went into this specialty in the first place, and the reason is because cancer is one of those diagnoses that's earth-shattering, right? So patients, when they get diagnosed with cancer, they become very vulnerable and very open and very emotional. And for someone like me who likes to talk to patients and is a very emotional person myself, it's really cool and really touching to get to know these patients at their at their most vulnerable state, and really bond with them over something as simple as as complex as life itself. We just have discussions about some of the most menial things, and it's very, it's meaningful for them. And for me, that's the best part of being a nurse, is having conversations with these. The first role I worked as an oncology nurse was an inpatient or bedside nurse. I worked on a solid tumor / medical oncology floor. The best way to describe one of these floors is like a med-surg floor, but everyone happens to have cancer. And it was a really good learning experience. Obviously, I got, exposed to pretty much every cancer type. Really, when patients are admitted an oncology floor, it's primarily for symptom management, primarily symptoms that can't be managed well at home, or inpatient chemo, that lasts several days. If they've reacted to it in the past, they're usually admitted, or obviously if the patient's not doing well. So I learned a lot. Obviously, I only worked there for 3 years. I decided that was not for me. The physical demands of working inpatient were not for me, and I felt like my talents were better suited other places. So yeah. Also an infusion nurse, and I worked in an infusion clinic during one of my travel contracts. An infusion clinic is a good transition from inpatient to clinic. It's really good for those who want to keep up their skills, their nursing skills, but may not want to be completely at the bedside anymore. It's a very, very, very fast-paced clinic. Pretty much just picture like an assembly line, right? You may have up to 70, 80, even 90 patients to see, a split among a brigade of nurses. So patient comes in, you give them their, whatever they're there for, which could be chemotherapy, could be blood products, could be electrolytes, could be fluids, could be injections, whatever. They get their stuff, you send them off, and then you get your next patient, and you do that until there's no more patients to be seen. So these are usually anyway, like they could be 5 to 8 hour days or 410s, typically 410s, but again, very fast paced, and yeah, good transition point. I've worked obviously is clinic nursing. It's where I am today. It's the role I happen to love most. So clinic nurses, you work side by side with an attending physician, with an APP, and with a medical assistant. And your role is you see patients with the provider. You do a lot of administrative stuff. You do a lot of stuff with insurance, so prior authorizations, medication refills. You're on the phone with the pharmacy, on the phone with the insurance company, whatever. You triage calls, you handle patient messages. You're pretty much the eyes and ears for the provider while they're seeing patients. And it's pretty cool because you have that kind of level of autonomy. You also get to meet these patients, and you get to track them from time of diagnosis to either cure, remission, or unfortunately hospice. So it is kind of cool to have that relationship with these patients. And that's really why I love clinic nursing, and why I think that's why I'll stay with clinic nursing. Last role I want to talk about was being a supportive care nurse, which is the role I'm currently working in, which I love. So obviously, supportive care nursing or palliative care nursing is not unique to oncology patients, but it is very helpful for oncology patients. Obviously, they're going through a lot of treatments that can cause a multitude of side effects and symptoms that need to be managed. So, our team is consulted when, the patient is having a difficult time managing symptoms, ranging anything from pain to emotional distress to fatigue. Remember, fatigue is the most common side effect from chemotherapy. It is one of the most difficult ones to manage. What else? Shortness of breath, obviously diarrhea, constipation, nausea, you name it, we handle it. And our role is really to optimize quality of life so that these patients can make it through their treatment. They can focus on themselves and on their journey. So another cool thing about oncology is the sheer number of certifications that are possible within this specialty. So I am a CHPN, which is Certified Hospice and Palliative Nurse, and I was able to qualify for this because the inpatient unit that I worked in when I first started, we had both oncology and palliative care services running at the same time. So I got a lot of palliative care experience, and obviously I qualified for those hours, and I was able to sit and take the exam. Obviously the most common certification for oncology nurses is the OCN, the Oncology Certified Nurse. There's also the BMT exam, there's a breast certified nurse exam. There is there's a bunch of pediatric oncology nurse exams. I only work with adults, so I'm not familiar with those, but I can ask my roommate. She'll be home later. She does pediatric oncology. But there's so many, which is awesome because a lot of other specialties don't have that. So another cool reason to become an oncology nurse. What up, fam? It's Em, your favorite oncology nurse, back with episode 4 of Tumor Tuesday. So it's March, which means that our focus today will be on colorectal cancer, or cancer that involves the colon and the rectum. So colorectal cancer is one of the cancers that has a higher risk of early detection due to the numerous screening methods that exist. So we will be briefly covering a few, but I will save the in-depth discussion on screening for another time. Most colon cancers start off as polyps, which are non-cancerous growths that can be found on the inner lining of the colon. Some of these polyps will stay benign, but some will become cancerous after a long growth period, about 10 to 20 years. So monitoring these polyps becomes critical, which is why screening is super important. So risk factors for colon cancer include the usual suspects like smoking, drinking, obesity, and lack of activity, as well as diets that are high in fat and include a lot of red meat. Other factors include age, those at 50 or higher are at higher risk, gender, and certain genetic syndromes like FAP and Lynch syndrome. The screening on average starts at age 50, but can differ based on the patient's risk stratification. Again, we're going to take a deeper dive into this in another video. So diagnosis is done through colonoscopies and CT scans with additional testing like blood tests to monitor tumor markers like CEA and molecular profiling to identify mutations such as KRAS or BRAF that can help determine treatment options down the line. So signs and symptoms include changes in bowel habits, blood in stool, a feeling that the bowel is not emptying fully, abdominal pain that will not go away, and weight loss. Stay tuned for part 2 where we discuss management. Welcome to part 2 of Tumor Tuesdays, episode 4, where we were discussing colorectal cancer. Now we're going to focus on prognosis and management. So the 5-year survival rate for colon cancer is fairly high at 65%. For earlier stages, the rate jumps up all the way to 90%, but for stage 4, unfortunately, it is only 12%. Regarding management, surgery is the most common treatment, and options include colectomies for tumors in the colon or protectomies for tumors in the rectum. It can be done in the neoadjuvant and adjuvant setting and is more widely used in rectal cancer due to the increased risk of local recurrence. Palliative RT can also be used to alleviate pain or obstruction. Therapies, again, can be used in the neoadjuvant, adjuvant, or metastatic settings. In the neoadjuvant setting, the drug of choice is capecitabine. In the adjuvant settings, regimens like FOLFOX or CAPOX can be used. Finally, in the metastatic settings, the regimens include FOLFOX or FOLFIRI, plus or minus other agents like bevacizumab, cetuximab, or panitumumab, depending on the molecular profile of the tumor. Oral agents like regorafenib or Lonsurf are also used as second or third line treatments. So if you haven't heard already, screening saves lives, especially those affected by colon cancer. 40% of colon cancers are caught in earlier stages thanks to these extremely helpful screening methods. So please do not hesitate to talk to your doctor and see if you qualify. So I hope you guys enjoyed this week's episode and stay tuned for next week. We're reviewing yet another GI cancer. Can you guys guess what it is?